It is a special honor for me to stand in front of you this evening to introduce Alejandro Chapa. And I'm, again, asking that I can call him by his first name because it feels like family. So Dr. Chapa, or Alex, is one of the first champions of patient blood management here in Prescott at YRMC. He currently serves on the following committees: critical care patient blood management, transfusion review, and antibiotic stewardship. Tells you that he's interested in improving patient outcome, and he spends a lot of time doing so. He is an active member of the Society for the Advancement of Blood Management. He will be speaking this fall at the SABM annual meeting in Grand Rapids, Michigan. His theme tonight is hemorrhagic emergencies in the 21st century. It is new drugs, new problems, and what it means for you. Please welcome Dr. Chapa.
All right, you may be wondering what's that all about. To convince me to come back this year, they promised me the band Scorpions. And so far, the only Scorpions I've seen are the ones in the backstage, and I had to kind of stamp them. Just so that I know, who was here last year? Oh, good. Well, this will be a little bit connected to that talk. Who was not here last year? Shame on you. Now, who was in some weird quantum superposition, both present and not present? Good, no engineers in the audience. Awesome. All right, let me see. Once upon a time, life was simple. My steering wheel looked like a steering wheel. The telephone was a telephone. I remember when you only had to mark 5 little numbers and complaining about how to memorize a 6th number. And when you talked about apples and blackberries, they were fruit, you know. And just like that in medicine, there was also simpler times. Oh, there's my fonts. Yeah, there you go. Simple times, good times. So in medicine, there were also simpler times where we only had so many drugs to use, and even though people bleed, the management was very simple. We had, discussions about how many times people had to fall before they were not a candidate for Coumadin. Would fight about how many, if it's 276 or 286 times, and we had sort of more of hard stops to medicine. There was a little bit of more freedom, a little more judgments, and we've always known that there's these diseases that need to be treated with blood thinners, whether you have an irregular heartbeat or you make clots on your own or because of cancer. And this is a picture here of what a clot in the lungs looks like. This should be your normal circulation, and all this gray stuff here should not be there. We would not be talking, you'd be dead by now, or pretty close. This is a stroke, doesn't look very well here, but all of that is gone. And actually this brain is swollen, you don't see this cavity on this side, so this is a bad stroke. And this is some of the reasons people take blood thinners, to prevent this hideous and heinous things. And of course, you made it through the stroke, but now you smile like that. So we take these things really seriously, and that's why you get blood thinners. And they're not candy. I mean, we call them drugs for a reason. Even if you take aspirin, there's a 2.6 or so chance of you bleeding a year. And the problem with these drugs is that as you get more medical problems, you start mixing and matching, and you end up having that risk go as high as my credit card bill when I enrolled myself with the one click on Amazon. And now, you put one thing and then another, and before you know it, the credit card is sort of busted. But just for instance, I'll draw your eye here. If you're on Coumadin and Plavix, your risk is about 12% per year. And this is done in the understanding that you have diseases that that are so bad that if you have a stroke, it'll be horrible. If you have a heart attack, it'll be horrible. And those risks are even higher than this. But you already start seeing where I'm going with this. So let's see. Historically, we used to talk about, how many strokes versus how many bleeds before you were not a candidate for Coumadin. We used to decide based on the risks. And I'm going to skip this just to kind of go a little quickly. And for instance, I'm going to skip this part. Here it is. So this is a picture of the coagulation cascade, and only to show that there's a number of different proteins that domino each other to make you clot. And we have drugs that pretty much can interfere in the good olden days only up here, nowadays a little further down, to keep you from making clots. And in the good olden days, the paradigm revolved around transfusion. We used to say we're holding the fort. So if somebody came bleeding, you transfuse them until they stopped somehow. And it was pretty much like a one-size-fits-all. If you need platelets, you got blood, whatever. It really was not very scientific. I'm polarizing, but I can't go through too much detail and be done on time. The shortcomings of this approach, and this is somewhat of a recent paper, was 2013 in Gastroenterology. This was what was published when we started getting in trouble with some of the newer drugs like Pradaxa or Xarelto. Whoopsie, no peeking. Pradaxa or Xarelto, this was the algorithm that was proposed by some of the medical societies. And my problem with this is, it's the best representation of what's wrong in hospitals and don't do PBM, where the emphasis it's in resuscitation. What means is sort of filling the tank up so you can keep bleeding it out. Only at the end, God darn it, there you go. Only at the end do we really look at stopping the bleeding. And that's my problem with this approach. That it really is, do it, there. It's like doing this, you're getting transfused sort of while you're bleeding out. So there you go, right? So here, if you would tell me that it makes more sense to plug up the bucket instead of keep pouring the water, why doesn't it make sense then to sort of have the same mindset when we're talking about blood transfusions? All right, let's see if we can make this go. Yes. So now the issue with management of blood and hemorrhage is it's a little more complicated. It's like relationships in Facebook, where everybody's complicated. Nobody's single or married anymore. I don't know. I'm not that old, but apparently that's the newest thing. Are you single? No, it's complicated. Good for you. Anyway. So here, there's a bunch of, this is just to show you we have an awful lot more options. You have Pradaxa, Xarelto, Eliquis, and they just don't work in the same spot, just the liver. You're starting to see a little bit of kidney metabolism. A lot of these assays here, even though I have them here just to show you, we really don't have them readily available. They're expensive. And even though we say there's no interactions, they are. And let me see, Oh, it didn't look very good. Oh, well, this was just, I'm going to skip this one because it doesn't look very good. This is a graph that everybody will in the medical community kind of has in their mind. The newer drugs are safer. When you look here, as far as the chances of them causing you a bleed compared to Coumadin, any of the newer drugs are considered to be safer. In other words, there's less chances of them bleeding, and it's led to a paradoxical increase in the prescription practice. Whereas before, our paradigm was like, well, I don't know, she's failed 250 times, maybe she doesn't need Coumadin. So there's a little bit of that part of the doctor that died away. This is actually from a journal in geriatrics, didn't get a lot of attention. But the point that I'm trying to show here is when you compare, for instance, major bleed or bleeding to the brain between, let's take Xarelto versus Coumadin, you see the difference is not that big. And you can go for any of the other drugs. So what I'm getting at is the risk is never zero. The risk is always there. The only difference is that some of these drugs we can turn off. And that's where it gets interesting for patient blood management. So we used to only putz around up here or here, and we could turn those drugs off. Means that if you got in trouble, I could give you something or do something to make it go away. Now we're putzing around further down in the clotting cascade, in that mechanism that makes you clot, and we cannot turn it off for the most part. And that's a bigger problem, because that means that depending on your circumstances, you may be bleeding 12 to a little more hours. But wait, just if that wasn't bad enough, there's more. We have the platelets, which are those little cells that actually bind themselves together with little pieces of fibrin to make a clot. And guess what? We also have drugs to get in the way. But anyway, we have aspirin and NSAIDs, and they'll make your platelets, the stickiness, so to say, changes. And in the cath lab, cardiologists, you also use drugs that actually completely block this receptor, which is the one at the end of platelet aggregation. Means it's the drug that works exactly at the end where the platelets stick to each other and to the fibrin strands. This paper actually goes to show you how aspirin really will affect your clotting. Even if you stop it, it can take 4 to 10 days. It kind of depended on patients until your platelets sort of begin working as they would have otherwise. And to reverse that effect with blood, it takes 10 to 12 units of platelets. So Dr. Chandler just spent an awful lot of time talking about the cost, and I had brought some of those issues in the previous conference. This is just madness. To give 12 units to reverse aspirin or Plavix in an emergency, it's just not feasible. And even if I did it, there'd be an awful lot of side effects and other things. So it's almost like saying that dying of tuberculosis is less bad than dying from the plague. You're really not comparing apples to apples. So to make things even more exciting, as we age, we get more medical problems. So if we're just dealing with one, it's easy to keep that balance. But as we grow older and we get more medical problems, you start getting more and more medications. So then the amount of interactions and the amount of things that can make you bleed certainly goes up. But the problem also is that we're being maintained by those. So if you start bleeding and all of a sudden I have to stop any of these may act up, which is part of the reason that the management is not that simple. So to make things a little even more complicated, this is already quite interesting. We also have other diseases that can make this even more fun. You can have cirrhosis where patients don't make clotting factors, or you can have issues with your kidneys that may make the platelets have issues with sticking or can make you more prone to clotting. That's where, for me, for instance, patient blood management is about teamwork. So do I work closely with, let's say, Dr. Nika or Dr. Kim from nephrology? Absolutely, because sometimes the treatment of the bleeding disorder may need dialysis. So we'll get there. Anyway, now to make things even more exciting, there's been a big change in the guidelines. The American College of Cardiology really favoring the newer drugs like Prolaxa, Xarelto. American College of Chest Physicians, it regulates pulmonologists and a little bit of critical care, also favors them heavily for the treatment of clots, legs, lungs, patient preference. Who wants to go for blood work and things like that. The issue with these things is, here you'll see, for instance, this is just to show you that guideline I was alluding to. It's preferred number one drug, any of those three, over any of the other ones, like Coumadin or shots in the tummy, which is going to increase the exposure. We also have a lot of literature that tells us that transfusions are not that safe. So then you start to see the problem, where we're being pushed by guidelines to use drugs that are dangerous, but at the same time, we don't really have a way of dealing with them. And what we used to do, which was transfusion, is not a safe option anymore. So just to set up a little bit of the stage, I think Dr. Chandler already covered that. I just wanted to point out backwards there. A patient in the hospital, their chance of getting a hospital infection is about 4%. You get a transfusion, goes up to 50. So for me, an internist, that's the biggie. I mean, if you just got a hip, do you really want it infected or what have you? So this paper then even complicates things even more. I read it and I cringed. It's a good paper, but it'll just show you. This was a paper just published in the Journal of Cardiology. You'll see March 2016, and it was, in essence, looking at people that bled into their brain. This is people in the previous paradigm would have said, you know what, you bled, it's a bad one. Maybe blood thinners are not the thing for you. And they looked, and the patients that actually, if you calculate the risk of stroke, it's still higher than the risk of rebleeding. So their recommendation was for high-risk patients still to put them on blood thinners. So you start seeing again how that picture becomes complicated. This paper here was looking at exactly the opposite. In other words, if you use this score, which is a score that doctors can use to predict the chances of bleeding, can you predict the chance of rebleeding again? And the answer was yes. And here you have pretty much the chances depending on the score. So you could go anywhere from 1 to about 3.4 or 4%, depending on the risk factors in the next couple of months. So you're tossed exactly back in the same spot you were. You have this beast of a problem that needs blood thinners. You've gotten in trouble, and the literature tells you that you should still treat patients just as aggressively. It's an uncomfortable position to be in, to say the least. And just to show you a little bit of the point that I'm trying to make, the American College of Cardiology, nothing against them, will tell you when to use Plavix or any of the other blood thinners, but it doesn't tell you how to deal with the bleeding from that. ACCP doesn't tell you how to deal with a hemorrhage from any of these newer drugs. Society of Hospital Medicine, it has some guidelines that are a little generic, and then the Society of Neurocritical Care and Critical Care do have some better guidelines. This is a slide from the summary of the ACCP on the treatment of blood clots, and this is their only comment on how to deal with blood thinners. If it's sort of like Coumadin, reverse them quickly with a really expensive drug. Anything else, they don't have a comment. So you start seeing the problem that these drugs are being sort of put out, they're convenient, but when something goes wrong, we don't have a good way to deal with it. And on top of that, there's gaps in knowledge. So let's say that as a doctor, you look for the answers. A lot of the patients have been excluded from some of these trials. So if you had a recent heart attack or a clot to the lungs, or you have very sticky blood from cancer or other reasons, they tend to be excluded for any of the trials that would use a reversal agent, which is funny because this is a lot of my patients. So you'll see how it becomes problematic. You don't get that answer. There's a fragmentation of knowledge, and so that certain societies have answers that others don't. And there's not like a free flow of information. Think of it this way, your OB may not be reading the guidelines from the American College of Neurocritical Care. And yet the answers may very well be there. We don't have really good ways of reversing drugs in a predictable fashion, which can lead to an overshoot. And there's not a lot of really good literature of when it's safe to restart blood thinners after particular problems. There's some, but it's not very clear. There's a lot of things that can bleed, and we have scores that tell you what are your chances of bleeding. But the problem with this is, as you've seen already in the other two trials, we still favor treating over the risk of bleeding because a stroke is more devastating, and we tend to think that we can treat bleeding a little easier. So we have all these areas of medicine, and their experiences don't necessarily overlap. So what's good for one area of the body doesn't necessarily work on another. For instance, orthopods will show me this paper and say, see, tranexamic acid, it'll stop bleeding. Yes, and I'll say, and it stops it up when you're bleeding into your lungs, and it also works if you've bled into your brain or around it. But in the stomach, there's no literature that it helps. So again, you see there's areas where the knowledge doesn't necessarily apply from one organ to the other. Now, if I was in an academic environment, I would contest this, but that's a topic for another time. I'll give you another example. Here, this paper talks about how steroids can increase your chances of bleeding into the stomach. And then there's this other paper here where they actually had a reversal, or they were able to turn off the effect of Plavix with steroids. So again, you see the knowledge doesn't necessarily overlap. Factor 7 works great if you're bleeding into your lungs. But then you'll see here, this is a little excerpt from neurocritical care where they say, we don't like it. It overshoots, makes people clot too much in a bad way. You can actually get a heart attack or a stroke. So it's no longer recommended. So we have these gaps in our knowledge, and that's just about the drugs. If I actually start getting into this in detail, they don't talk about platelets, yet we have drugs that mess them up. We don't talk about calcium or fibrinogen, which are other parts of the blood. So then when we started the PBM program in the hospital, when I had to talk to my partners or my colleagues, there were all these gaps in knowledge, but all these challenges as well. So when we were going to bring out an approach, it had to be comprehensive. It had to be for everybody. So here, this is, again, a different area, trauma. And they looked at what is the biggest contribution, if it's the fibrinogen, which is a little protein that helps you clot, or the platelets. And they found that in this study, the platelets contribute a little more to the strength of the clot. Here, they were talking about fibrinogen in shock. It's a journal I read a lot. And they talked about not only does it help, but you should address it early. In other words, that we should be looking in patients that are having bad bleeds early on what is their fibrinogen, and it should be treated early on, not expectantly. This was another one, anesthesia, critical care. They looked at calcium, which is a mineral that you need in clotting, and they actually did find increased mortality if the calcium was low. So you start seeing where I'm going with this. This was another one where they looked at the strength of clots, depending on the level of the calcium, not so much mortality. And again, the patients with better calcium did better. So the challenge is not only to stop the bleeding, but to prevent the overshoot. For instance, we use a drug called Kcentra, which is like a synthetic concentrate of clotting factors. It has an intrinsic 2 to 7% chance of making you clot in a bad way. It's like a stroke or an MI. Factor 7 was worse, 12 to 24%. That's why we took it out of the critical care guidelines in neurocritical care. And then, of course, when you reverse this, you have the risk of letting some of those diseases that you were supposed to be treated for act up on you again and give you some problems. So the issue, this is complex, is what we've been talking about, is you have to manage not only the hemorrhage, but the diseases that you were trying to prevent or treat in the first place. So it's a little bit like, you know what I mean? You're not choosing between good and bad. Sometimes you're choosing between bad and a little less bad. So, I mean, do I jump? Here, boy, here, boy. I mean, it's not easy. So I'm going to show you again why I feel the other guidelines don't work in the PBM, with the PBMI on this. They're too generic, they're not aggressive enough, and they don't include everybody. In other words, if your whole paradigm is to transfuse as needed to hold the fort, if you're a Jehovah's Witness or have other reasons, you're out of it. Well, that shouldn't matter, right? I mean, technically I'm a doctor for everybody, right? Right? Oh, thank you. So for instance, let's look at this again. You know, this is not very aggressive, and if you're a Jehovah's Witness, you sort of stop right here. So that means I'm only going to give you fluids. By the end of this talk, I hope you can get a little bit of an idea of all the other things we can do to make you stop bleeding when there's a problem that have nothing to do with blood transfusion, hopefully. Anyway, so what it comes to is we can't keep doing this cookie cutter approach. We can't expect to treat everybody the same. because not all bleeds are the same. The brain is not the same as the stomach's not the same as the lungs, and the drugs, like you've seen, the ones that work in one place don't work on another. Matter of fact, they make it worse. So in an ideal world, a world without walls, so to say, you guys didn't get it. Okay, it's okay. I'll explain it later. You would want guidelines that are organ-specific. In other words, like the neurocritical care, they have their own guidelines just on bleeding on the brain. They're beautiful. I recommend you read it next time you go to the bathroom or something. You want an approach that respects patient preferences, that can still deal with underlying conditions, and that has somewhat of a low risk of adverse reactions. So can we do it? I don't know. Stay tuned. These were the first guidelines published, I think, in 2011 by New Zealand, dealing with hemorrhages or bleeding from Xarelto. And you will see here, again, mild bleeding, sort of watch it, moderate bleeding, stop it, call hematology. I mean, okay. Compression, surgical intervention. You see, activated charcoal. I've done nothing to make you clot. So what happens if it's severe bleeding? Then you get something to sort of try to make it stop. That's why I think this is not good enough. These guidelines are from the Society of Hospital Medicine, and they're a little better. I have to say that, I'm a hospitalist, right? Whoa. Woo, tough crowd. Anyway, so here you'll see that they do split the bleeds by organ, okay, which was a big advancement compared to the generic New Zealand guidelines. And you'll see that the next thing is to try to start any of the reversal agents, and this is the first guideline that talks about how to reverse platelet if there's an issue with aspirin or Plavix. And this was huge, but it didn't get a lot of attention because not everybody likes hospitalists. But you'll see there's an awful lot more tools here that were not considered, even dialysis. That's why I said I work very close with my nephrology partners. But as good as they are, they're not that great. We can do better. The issue here is that in reality, the guidelines were pushing you for the more aggressive treatment on the patients that were bleeding the worst. And again, that alienates moderate or mild bleeds on people, especially that have religious preferences against blood products. So for me, it's still not good enough. So this paper here is from Neurocritical Care. And in these guidelines, they go through a tremendous amount of effort to explain every single drug that we have. And is it not only good or bad, but is it going to work? And is it going to cause any more harm for every single type of bleed that you can have in the brain? And it's the only guideline that is that comprehensive. And I really wish we had something like this for every other organ. So stomach, colon, lungs, or what have you, and we don't. So this is sort of the backbone that we've used to look for a more comprehensive way of managing with bleeds at YRMC. So we have a number of tools. We can give you concentrates of plasma that are made by bacteria, so they're not humanly derived. You can use cryo, which is a part of plasma that has just the fibrinogen, of course, platelets. This is a drug that sort of prevents the body from breaking clot off or down. So in other words, once you've made it, your body will want to destroy it. We won't let that happen. We'll let that clot adhere. And then we have other drugs to reverse aspirin and Plavix. And DDAVP is a drug that used to be only used in people with renal failure, but there's actually a lot of literature on it reversing aspirin and Plavix, regardless of the renal function. Where did I get that? Neurocritical Care. In other words, from the Society of Critical Care for the Brain. Protamine reverses some of our other drugs, and then dialysis depends. The problem is that I don't have a very good way of measuring how fast to reverse this, so it's not that good. And this one here, I put this slide just to show you how plasma really, for me, it's falling out of favor, because when you get somebody that's going to have a bleeding problem and you wanted to reverse it with plasma, you end up using a tremendous amount of fluid. So it's not only costly, but most of my patients are senior enough that they will not tolerate it. They'll get in trouble with their bleeding. So it's normally, some people will need 2 to 4 liters. So it's just not going to work. And then furthermore, some people are still using plasma to treat numbers. So in other words, people are using plasma just because there's nothing else to do. And here, this is a paper that shows you that when the INR, or it's a way we measure how thin your blood is, it's less than 1.7, it won't work. So all of these pieces, as you see, and my talk hopefully feels that way, broken and discombobulated, it's because that's the medical knowledge right now. You got pieces all over, okay? So then, how do I manage this? I start remembering all of these papers, the calcium, the fibrinogen, they're important early on. And all of a sudden, the picture is more complete. Everything matters. So my approach has to encompass everything. And not only that, but it also has to be realistic. So in other words, some patients may not want everything done. So then there's other ways we can keep them comfortable. So what I've proposed to a lot of my partners is look at the calcium early on. Make sure it's normal. If they have any drug that needs to be reversed, do it aggressively from the beginning. Make sure that fibrinogen, which is a building block for the clot, is not only present but in appropriate levels. Make sure that you've reversed any drug like aspirin or Plavix early on. Don't wait for it. And if it's really bad, you can also prevent the clot from being destroyed. So when you do this, you're tackling every area where the patient can get in trouble and bleeding. And I'll show you some examples later on to show you that there is some light at the end of the tunnel, and it's not a machine coming your way, you know. We have some new drugs coming as reversal. So hopefully in either this year or the next one, we'll have specific reversal agents for either Xarelto or Eliquis. Pradax already has one. Here it is, Pradabine. So it's a specific reversal. I don't think we have it yet. This is from the journal Thrombosis and Hemostasis. This is to show you this is the type of research we really need to be focusing on. What they did was answer that question. Somebody comes for emergency surgery. They've had aspirin and Plavix. How quickly from stopping can they go for surgery? So what they did is they waited. For a couple. Let me go back. They stopped it within 2 hours before surgery. They gave them 2 packets of platelets. They went for surgery 6 hours after they started the aspirin, no changing bleeding complications. What's amazing of this is that I just told you that most patients would have gotten 10 or 12 units of platelets to reverse the aspirin and Plavix. This is the first paper that really shows you it's not necessary. It's about the timings. So we need more papers like this to tell us the right timings on a lot of our interventions. We're getting this product called Sanguinate, which is going to be a synthetic blood. It's approved for people with some blood disorders, but we still don't have it approved for everybody. I think Jehovah's Witnesses are going to get trials soon on emergency circumstances. I think sickle cell's already approved, but that's actually quite interesting. We have some new technology that will allow us to test your blood by in a non-invasive fashion, so we don't have to be bleeding you to see how low you are. I think we are getting our monitors, I think with this capability sometime in June. So it's like an early Christmas present for me. So the take-home message is that there are ways in which we can deal with this, but it has to be more comprehensive. It's not about falling back on the blood. It's about looking at the whole picture and making sure that everything is as optimal as can be so that your body can heal itself. So let me show you a couple of papers a couple of examples. I didn't want to use the patient's images for, I guess privacy purposes. Some people get upset if you put their name in public. But for instance, let's look at this one. This was a 90-year-old gentleman. He was German, Johann Dar. I think I called him Yoda for short. And he had a bleeding here in the back part of his tummy. The way this behaves is people will bleed for 2 to 3 days. They end up getting about 10 packs of blood. Sometimes they get about 10, 12 packs of plasma, platelets just because, why not? And they stay about 10 days in the hospital. This patient, what we did with this new approach was actually, he got 1 unit of plasma, he got vitamin K, he got Kcentra, and he stopped bleeding within an hour and a half. Left the hospital day 4. So, and this was a 92-year-older with heart failure. So that to me is what actually makes me all warm and fuzzy inside. Now this one, you can't see it very well here, but the liver is here and it should be coming down here. This is actually a cyst. Think of it like a pimple. He bled 2 liters into there. So this guy had a recent heart attack. He was on aspirin and Plavix, and he was now too unstable to be transferred to a different facility. So they called me to see this gentleman. He got tranexamic acid, did the AVP, and he stopped bleeding within an hour and a half. He went for an angiogram when they go from your groin up and take a look-see, and they squirted the contrast. There was no active bleeding. After that, straight to surgery. They took this out. Patient left for rehab on day 4, I think. No blood needed. So it can be done, and these are really, some of my more dramatic examples. This is a patient that I had with Dr. Thomas. He was on Plavix and hit the windshield unrestrained, started bleeding into the brain, and this gentleman got 2 units of platelets, and he got DDAVP and tranexamic acid to prevent the clot from breaking down. Went for surgery. All of that was evacuated. Within 2 days, he was in rehab. Within a month, he was walking like there was no problem. So now, if you were a Jehovah's Witness, I would just keep the the platelets, and just do this, the DDAVP and the tranexamic acid. But you see, this approach is for everybody, not just for people that can take blood. So now I'm going to show you how roughly, because we don't have the resources to monitor every single disease and look at mortality and things like that, but roughly these are some of our numbers. This is a Prescott population. We're a little skewed to the more mature side of things. And for a heart attack, you'll see that our survival is going up, even though when you're even in your 90s, close to half of you guys should pass away from this. So what this means is that, and I'll get to that in 2 seconds, or 2 slides actually, heart failure, mortality is about the same, even though we expect you to die by the end of 5-10 years in a big chunk of you. Pneumonia, if it's not that bad, 10% die. If it's really bad, 30% of you will die. Here, our numbers are pretty consistent, and this is despite the fact we now have the swine flu as the quote-unquote normal flu, and we really have had some serious pneumonias in the last 3 to 5 years. So where am I going with this? When we started our PBM program, and I'll get to that in a bit, we started in, I think, 2012. There was whatever amount of blood being used, okay? Till 2014, we've dropped it about 40%, even though our patients are getting sicker. And despite that, we're maintaining or improving on survival. So these are not numbers from Sweden or Germany. These are your numbers from our community, just to show you that we can do it, and we can do it better. Of course, 30% depends on what you're looking at, plasma or blood, whatever, but it's about 40%. So The great thing of bleeding is that eventually it stops. And I take great comfort on it, you know. The question is how. In the old paradigm, it was kind of that watch and wait, observe, transfuse. Our new paradigm is to try to be more aggressive from the get-go to prevent you to, you know, till the doctor sees you now, you know? And don't get me started in HMOs, because then you really are going to wait. And that's all I got for you tonight. So, our next speaker is kind of like the cherry of the pie. He's not only worldwide known, recognized, loved, venerated, whatever word you want to use for him, but he's also one of the smartest person and one of the nicest people you'll ever get to meet. I'm very humbled and privileged to call him my friend. Please welcome Dr. Pierre TV with his talk, The Patient Has Spoken.